Testing the microphones for the back of Dr. Over at Light. Can you hear me? We're testing the microphones. Can you hear us in the back of the room? Dr. Over at Light? He can't hear me. Hi, John. Can you hear me?
Yes.
Oh, okay, all right. So we have some wonderful guests with us from around Southern California and as far away at the moment as from Germany. Can you raise your hand and introduce yourself?
Hi, my name is Claudia. Now I'm working for Kaiser Permanente.
And then we have from Sweden's Karolinska Institute, Professor John Overtveit, who many of you know. He's part of our RightCare technical expert group and has been a RightCare enthusiast for many years now. So thank you for adding us to your schedule. John is going to be with us also at Stanford in a couple of weeks. So lovely to see a nice crowd here despite the really challenging weather, and we have a lot of new faces here. We don't normally go around the room and introduce ourselves, but can we just quickly, and I mean quickly, just your name and organization, go around the room and just project, please. So we'll start with Jean.
Hi, I'm Dr. Shahdadpuri. I'm the VP Medical Affairs for HealthNet, and I've been attending New VP for a while now. I feel like we're family, and then there are new members of the family being added each time. And I'll go to Scott.
Yes, let's go to Scott.
Hi folks, Scott Flinn, Blue Shield, California.
Neil Kaufman, Canary Health.
Robin McBride, HealthNet.
Quickly.
Rosa Calvasanco, HealthNet.
Elisa Stomsky, HealthNet.
Christine Castano, Healthcare Partners.
Anthony Brony, I'm a consultant.
Peter Konashiga, Internal Medicine from Memorial Care Medical Group.
Claudia, Kaiser Permanente.
John.
John Overtveit, Karolinska.
Tion Turner, Novo Nordisk.
Amanda Calvert, Blue Shield of California.
Marissa Fortuna with the American Heart Association.
Jen Leung, Novartis.
Chanchal Yadav, almost HealthNet.
Lydia Simon with Memorial Care.
Jason Dugan with Memorial Care.
Jessica Kwan with Memorial Care.
Cindy Giamberti with Guess Who, Memorial Care.
Marnie Baker with Memorial Care.
Andy Spicer, Novartis.
Oliver Coates, Watts Healthcare Corporation.
Keith Evans, Consultant.
Joel Handler, Kaiser Permanente.
We have so many special people in the room. I can't take the time to elaborate about the wonders of the many RightCare enthusiasts in the growing RightCare family in Southern California. But before I have my illustrious cardiology HealthNet co-chair say a few words, I want to just say that we are, I feel so grateful of all of your efforts to get here, not only today, but over the many years, because we do come from the four winds to do our utmost to use the best of science to save patients. So many patients are being lost and to disability and death due to completely preventable heart attacks, strokes, and diabetic emergencies. So one of our great Right Care heroes along the way is Dr. Scott Flinn, who will be speaking in a couple of minutes. He, among the many wonderful things he's done in his career, served 2 tours with the Navy SEALs in the Middle East. And then he served a tour of duty with Patty Hanley in San Diego, driving the medical groups to such heights that we reduced the rate of heart attacks by 24% in 4 years. And that was sustained at 22%, which equated to 3,826 fewer acute myocardial infarction hospitalizations over a 6-year period, and a savings of $86 million across San Diego County. And RAND estimated that if those performance improvements had occurred across the state, it would have saved the state $935 million over those 6 years and over 22,000 acute myocardial infarction hospitalizations. And as we know, with that comes a great deal of family devastation and falling into poverty, et cetera. So Scott Flinn really knows how to drive performance improvement, and I'm so hopeful that with his move to Blue Shield that he will be able to take the impressive learnings to try to spread them statewide. So we'll be hearing from him in just a moment. He's going to have to leave us right at 12:15. So Scott, why don't you make your way up here? Carol Zaher, cardiologist from HealthNet, will say a few words, and then we'll jump into your slides.
Yeah, hi. Thank you very much for coming through this inclement weather. And I'd like to say thanks to Hattie. Hattie's been doing this for over 10 years now. She was the instigator and the persistence for how we've made some achievements, as she just mentioned. So it's been slow going, but it's picking up speed, and we'll find from our lectures today that we are really starting to make some inroads. There's still a lot of work to be done, and we appreciate that you're willing to take on these missions with us. So with that, I'll let Scott come up. Scott, what was your hardest tour of duty, the Navy or Hattie?
Oh, Patty by far. Not even close. Thank you all, I appreciate that. Hi everyone, I'm Scott Flinn, Regional Medical Director of Blue Shield. I've been with Shield for about 4 years now. And what I'm presenting on today is our 2018 annual update. And I'm going to talk a little bit about some other best practices and experiences we go through. So why am I here? In October of 2015, Blue Shield acquired Care First, which is now called Promise Healthcare, as of January 1st. And as part of that acquisition we were mandated to participate in the Right Care initiative, and also develop a plan to try to get to the 90th percentile nationally for the Right Care initiative metrics. So that's why we're here. We're participating in the UBPs, and we've developed our plan, we're executing it, and what I'm going to do today is show you that progress to date of what we've done. So our strategy really was to figure out how we're going to incorporate this in a much larger scale across Blue Shield. So hypertension, diabetes, and readmission reduction are our top 3 quality initiatives for Blue Shield, and we've actually incorporated that into our long-term executive bonus program to reinforce that. We also have quality incentives for our provider partners to help guide that in both IHA and a quality incentive plan for our ACO partners. So we're putting our money behind it too, as well as developing those strategies. We're participating in all the 3 Right Care Initiative chapters, and as you know, the goal of Right Care is to eliminate strokes and heart attacks by attacking the 3 modifiable risk factors of diabetes, hypertension, and lipid control. I know I said that once or twice before. That's really what we're doing. And when we're looking at this, as we're looking at it strategically, you got a Right Care in LA, you got one in San Diego, you have one in Sacramento. Where was the one large population center? You had nothing. And that was right in our home area of the Bay Area. So in conjunction with Hattie and some other folks, we've helped to get the Bay Area Right Care Initiative group started in November, and that was a great discussion. Did you record that, Hattie?
It It is recorded. I've watched 3 of the 4 videos. And yes, so RightCare.Berkeley.edu has the slides and the video of a really intense, wonderful session about a new approach.
So, yeah, the focus was really on coronary artery calcium score, and I don't know how they pulled this off, but we had both USPSTF there and clinical experts arguing the merits and the utilization of that as a screening test or other ways to utilize coronary artery calcium screening. So I would encourage folks to take a look at that. It was a great discussion and very worthwhile, I thought. So what a great way to kick it off. And this year, or this month's going to be Jim Duttle from Kaiser talking there too. So that's a great one too. If you can't make it in person, I would encourage you to take a look at the recording. So as you know, as a health plan, we don't provide direct care. We rely on our provider partners, such as some that are in the room today, to do that. And so we have to enlist those provider partners in improving their performance, and that's the way we're going to drive that change. So we developed a 3-part plan to do that. First part was engagement, get folks interested in it. The second part is how to do a self-assessment to see where you are and look at those opportunities for improvement. And then, of course, the last part is to execute and track that progress. To date, we've had 26 provider organizations involved in the RCI efforts, and we have 14 targeted for the near future. We hope by the end of this year coming up with 40 partner organizations in this effort. And some of you are in the room today, and thank you for your participation. The provider engagement presentation has 4 major points it emphasizes. Hypertension control can have a dramatic impact in a short period of time. And you'll probably hear this theme over and over again. What can you do near term to reduce strokes and heart attacks? And the near term answer is hypertension control. The long term answer is lipid control, and that provides the greatest impact, but it takes longer for it to occur. Implementing some of these best practices are relatively easy and cost effective. They don't cost a lot of money. They just cost some organizational time. And there's some published literature suggesting this actually works, and Hattie alluded to that, and we'll show you some of that at the end here.
And they're on the back of our project brief there, the famous RightCare triangle that we worked on together, which is the formula. If you do these things, you will hit the 90th percentile. So sorry to interrupt you, go ahead.
No worries, and you're probably not doing as well as you think you are. And this is that self-assessment part we're looking at that we do. So, and there's a lot of this, and I know Kaiser, Joel will be presenting here today, fellow Steelers fan. Looking forward to that. But a lot of this was borrowed from Kaiser, and Kaiser has done such great work on this and going forward. And we're really adapting a lot of this from them. So a lot of credit to give to our partners at Kaiser for sharing this. And there's a saying we adopted in San Diego when we started this, because when we started the RightCare there, we had groups like Sharp and Scripps and UCSD that typically wouldn't even get in the same county together, except because that's where they're based, much less walk in their room together and talk about how they can mutually aid things. And we call it co-opetition. And they left the knives and the guns at the door and worked on it quite well. And as Hattie alluded to, we'll show you the results of some of that. But again, this is from Kaiser, and it's really how to prevent 1 in 6 of your high-risk hypertensive patients from dying from a stroke or heart attack in their next 3 years. So this is going to show you how hypertension control can actually get a short-term effect. Again, this is from Kaiser. Jim Duttle gave me the slide. 20 uses all the time. This is the death reduction, 17% in 2 years. So this is the Kaplan-Meier curve. If you have someone right here, ACE, thiazide, and atorvastatin 40 appropriately, that's the reduction, 17%. 17% sounds like a small number, but it's really 1 in 6 when you extrapolate it that way. And the high-risk hypertension folks are those 55 and older with hypertension. When you do your risk calculator, that's the group that falls into the quote-unquote high risk, and that's 1 in 6. And we all know those patients. We've all seen them. You all may remember Tony Sperano, who was the head coach for the Dolphins and assistant coach of the Vikings. He was 56 years old, same as me. He went into the ER on a Thursday. They kept him overnight, washed him. I don't know the exact clinical details. He went home Sunday morning, first thing in the morning, had a heart attack and died, age 56. Okay, so we all know that there's these patients out there that are relatively young. I mean, I think 56 is really young, right? Don't you guys?
Just a baby.
That's right. It's all relative, right? So that's who we're talking about, 1 in 6. We all know these patients clinically, And if we're not aggressively treating them, we're doing them a disservice. So what are those best practices? They include implementing a treatment algorithm, intensifying the treatment rapidly, implementing a care team which has a pharmacist and a CDE on it, and measuring your success and publicly reporting the outcomes. When we say publicly reporting, I don't necessarily mean he was reporting it out nationally. I mean internally within the providers. Providers is their general nature are somewhat competitive, right? Which doctor have you met that doesn't think they're all 90th percentile, right? They all think they're 90th percentile. So when you show what the actual numbers are internally, sometimes you get some very interesting results and motivation from that. So that's what we mean by that. This is the San Diego hypertension algorithm. You've probably seen this before. Modified directly from Kaiser. San Diego adopted it, and then different groups within San Diego were adopted internally within their groups. The thing that tends to get modified sometimes is calcium channel blocker. Some of the groups, when they run it by the cardiologist, they want a different calcium channel blocker. But overall, oops, sorry. Overall, starting with that combination of an ACE inhibitor with thiazide seems to be the most effective to get folks started on right off the bat. And no one has really changed that particular part. And the calcium channel blocker might get changed depending on what they want. And then the next step is beta blocker, or spironolactone. And you can see down at the bottom, for those with high cardiovascular risk, consider adding a statin according to guidelines. And a risk reduction of 25% in cardiovascular events. Again, not quite as quick as hypertension, but more effective than hypertension. Why combination med? You can see if you just add an ACE inhibitor, you drop the blood pressure to 9.7 millimeters. If you add the thiazide to that, just a little thiazide, you drop it 25 millimeters. So that's your biggest delta right there. That's why it's recommended to go ahead and start somebody on the combination medicine. Adding calcium channel blocker adds a little bit more, and then if you add 4 meds, you can see it's a little bit more. But that's the biggest bang for the buck, is starting them on the combo med. So why do we recommend having a pharmacist on the care team? Hi, Chloe, welcome. How you doing? In 2007, there was a study done at UCLA. It was an NIH-funded study. It showed that pharmacist-assisted hypertension control did much better than usual care. So the pharmacists can work at the top of their license under a collaborative practice agreement. They can intensify the drug therapy per protocol, order monitor-related labs, address the side effects, work with the patients and monitor for med adherence, and keep the PCP informed. And that's really one of the tenets of the RightCare initiative, is trying to let people work to the top of their license and let them do the best they can. And when you institute this, it's amazing the results you can get. Usual care, so self-confession here, I'm a family practice doc, family practice sports medicine doc. And I know when I'm in clinic and I'm seeing patients and seeing hypertension patients, titrating their blood pressure medicines is not the best use of my time. I can do other things. Pharmacists can do this just as well, or if not, probably better than I can, and that's what this 2007 study showed. And using this protocol, which you can have a collaborative practice agreement and sign this off with your physicians, they can go ahead and treat folks, and they do much, much better at getting that medication adherence and intensifying that rapidly. Usual practice is a family practice doc. I see someone come in, they say you got high blood pressure, we need to treat it. Oh, doc, I'm going to diet and exercise. You see them back 3 months later, they haven't done anything, the blood pressure's still up. You see them again, okay, I got to start on medicine. I start you on hydrochlorothiazide 12.5. I'll see them back in 3 months. And nothing's really changed because that's not enough medicine, and then we work on it, and a year later, they're still not under control. And that's what happens in my practice, and it happens in a lot of chronic care practices. With the pharmacists on that, every 2 weeks, they're following these people up and intensifying their medicine until they're under control. And the reason that's important, again, is that 56-year-old person who's at high risk, 1 in 7, okay, or I'm sorry, 17%, 1 in 6 are going to have an adverse cardiac event in 2 years, all right? That's people we all know. So that's why it's important to intensify rapidly and get them under control quickly. This is also data that Kaiser published. They started using the combination pill and really enforcing that in their algorithms, and the pharmacists could actually monitor the percentage of folks that were on these combination meds, and that's the graph on the right. And as they started working on using the combo pill right off the bat, you can see in this
The data's wrong.
The data's wrong, right? Of course, I anticipated that question. I wasn't born at night, certainly not last night. You can see the gray hair, right? So I had that ready. So my next slide actually was his patients. So he had almost 100 patients. And of course, what happens? He's reading through the patient list in front of everyone, just in a room. Actually, there was more docs in there than this. And he goes, patient number 5, that's not my patient. He said, okay, John, that's nice. What about the other 98? There was silence, and we moved on for the presentation after that.
Were you wearing a bulletproof vest?
No, and this is why medical directors last 3 years, right? Because there's sometimes you have to take risks and be willing to ruffle the feathers a little and get that change going. And sometimes it wasn't meant to be mean, because what we were offering next was an opportunity to how to solve that issue. So what we had done, we had just brought half an FTE of a pharmacist, and we were developing our collaborative practice agreement based on the RightCare model. And so there was a lot of hesitation, to say the least. It was interesting because we had already we used to have a nurse running our anticoagulation clinic, and then we switched to a pharmacist. The nurse did a great job, and the pharmacist came in and did an even better job. Got up to quality standard equal to or better than what Kaiser had at the time.
It was the best in the state.
So it was really good. And we said, all right, so we know they can do this. It's a leap of faith to take it to hypertension control. I was not a fan personally. I thought this is not going to work. Being a typical practice primary care doc, I'm thinking, hey, this is my realm. I don't need anyone else messing around in here. Stay away. That's my patient, right? So we got a couple of clinical champions, and they signed on, and they started doing it. And one of them was one of our internal medicine docs, who was 2 doors down from our cardiology department. And his numbers went from 55% control to 78% control in a couple months. And so the next quarterly meeting, when I flashed up, here's the results now. John was still at 30-some%. And this other guy, Dennis, had gone up to 78%, and a couple of the other clinical champions had jumped up also. And everyone's looking at this now, and the next thing I know, I had a different problem. I didn't have pharmacy time, because everyone wanted to have it. And so it took its own hold, and eventually John came around and said, yeah, I'll do that too, and his numbers, he had, of course, he said, my patient, what's the second thing, right? Dad is on, what's the second thing? My patients are sick, right? Well, in the cardiology practice, that's probably true. However, it shouldn't be 33% control, right? So we got him up to about mid-50s. He hovered between 55 and 60% after that, after we got the pharmacist helping him. But he did improve greatly, and that had got allowed our group as a whole to go over up. We ended up, after about a year or so, up in the 78% range of hypertension control, as you know, is over the national 90th percentile. Here's another one, this is alluded to on your title there. I still see patients. I moonlight in urgent cares at Sharp in my old group. And the policy this group instituted was if someone comes in and they check in and their blood pressure is over 140/90, they're going to get a blood pressure recheck before they leave the clinic. Okay, that's a nice policy to institute. How do you enforce that? And that was the magic they really did. And so they actually tracked that to see who got that repeat blood pressure done before the patient left, and they publicly reported that monthly. It was also their clinical quality goal for the year, and it's tied to their bonus program also. So publicly reported, money tied to it, had executive sponsorship. When it's elevated, and it stays elevated, you look at it and decide, okay, follow up with your PCP on this, and you alerted the PCP and the EHR that your member needs to follow. Or if it's highly elevated and they had symptoms, they would be sent to the ER, but that was a very, very small number. And so when you look at the literature on that, there's very few people that actually need to go to the ER, even if their blood pressure is 190 or so, over 110. There's a lot of literature that says that's okay to have follow-up as an outpatient. So that was publicly reported. Their numbers have come up overall over 80% for hypertension control, and this was a big part of how they got there. And kudos to them for instituting that and following up on that. Another example of the best practice. So does all this work? Patty alluded to this. This was what was published in November of 2017. Here on the left is heart attacks. Here on the right is strokes. The dotted line is statewide. There is a drop in heart attacks of 7%. That's great to see. In San Diego, it dropped 23.5%. Strokes did drop faster than in the rest of the state. I mean, they did, but not significantly different. But it's great to see that stroke rate dropping also. Okay, that's great. That shows 2010 to 2014. Has that persisted? And this article was just published in Health Affairs, and this shows that this for 2 years after that, up to 2016, the change in heart attack rate in San Diego continues to separate from the rest of the state. It was 22% for the next 2 years. So again, correlation does not make causation. But if you implement the whole county doing these things and really working hard on hypertension control, lipid management, diabetes control, you can get results. We couldn't think of anything else that caused this. Is it just happenstance? Sure, it could be, but it's unlikely. So again, correlation does not make causation, but you tell me what else happened to make that happen. So what makes San Diego different? That co-op petition we talked about and the data sharing group help to develop trust so people could actually share those best practices. So we would see the 8 best practices metrics that were going on. You might see that Scripps was at the national 90th percentile, and Sharp or my old group or somebody else wasn't there, so we'd have Scripps present. So what did you do to get that result? And then there'd be another one on diabetes control. So how did you get that result? And we talk about how you get those results amongst each other. So even though it's, quote unquote, sharing what you're doing, trade secrets with your competition, a rising tide lifts all boats, and as you can see from the results, what happened in San Diego because of that. So what about Blue Shield? So we started this, we were tasked with this in late 2015, developed a plan in 2016, 2017, we only had 7 groups that were engaged in this. And so this is the latest. Thank you, Hattie, for providing these a couple days ago. Here's the measurement year 2017. Okay, remember, we're in 2019, so this is the latest data we have. This is from measurement year 2017. And this shows the health plan numbers of where folks are. Our friends at Kaiser are the two up here. Here's the National 90th, doing well. Here's what Sharp Health Plan I was just telling you about has done, and some of the efforts they've done in instituting best practices. So they're the purple one coming up here. Okay. Blue Shield, this is us. We're actually declining. So